Hi, everyone. Thank you so much for joining us. Today's topic is a new diagnosis of atrial fibrillation. We have a couple of videos out that go over atrial fibrillation broadly and atrial fibrillation ablation specifically. We try to put in a lot of detail, and I talk kind of fast, so it's a little bit compressed, and I don't want anyone to be intimidated, particularly somebody who is new to this topic. So the focus today is for someone who has recently been diagnosed with atrial fibrillation to tell them what you might expect from the first clinic visit to talk about the plan for atrial fibrillation. If you want more detail, certainly check out those videos. But I hope that this one just gives a nice, simple overview of what to expect. Okay. Today, we're going to go over the heart rhythm in background. We'll talk about what the consequences of this abnormal heart rhythm is and tell you specifically what to expect with regards to an atrial fibrillation appointment. We'll talk about the tests that we do, the goals of treatment, and how we make a plan for you. So first of all, as you may know, atrial fibrillation is the most common arrhythmia, so by far. So you are in good company if you have it, and we have a lot of experience with it. It is a fairly broad topic, and it's not always straightforward. Some arrhythmias are very straightforward. This is not one of them. Sometimes there's a little bit of nuance, and there's always a need to individualize the treatment for each specific person who has it. It does have some consequences, and those consequences need to be treated. You're going to hear this several times today, but the big three things are we have to prevent stroke, we have to control the heart rate, and we have to make you feel better, oftentimes by restoring normal rhythm. So I will give a little bit of a background. If you want a little bit more detailed of a background, you can look at the other videos. But what happens with atrial fibrillation is that the heart is a muscle, and it has 4 chambers, 2 on the top, 2 on the bottom. The 2 on the top are called atrium, or atria, and the 2 on the bottom are called ventricles. With normal rhythm, typically what happens is when we're in normal rhythm, electricity comes from the top, and it courses like a wave of electricity from the top to the bottom, from the top to the bottom. What happens with atrial fibrillation is that nice, beautiful rhythmic wave gets disrupted, and what you end up having is chaotic electrical activity all through the top parts of the heart. And this has several consequences. The first is that the heart becomes irregular at that point, and some people feel palpitations where the heart is no longer regular, and sometimes it also is fast. On top of that, because you're not getting a synchronized squeeze of the muscle, you can often feel fatigued. So the heart isn't squeezing well, and people can feel fatigued. And then the most important consequence is that when the heart isn't squeezing well, it has the propensity to clot. And those clots are very, very important because those clots can go up and cause stroke. So that's the big picture. So the goals of atrial fibrillation management are to prevent those consequences. Number 1, we need to prevent stroke. Number 2, we need to control the heart rate. And number 3, we need to make people feel better, often by restoring normal rhythm. So when you come into a clinic, what we'll do is we'll talk about atrial fibrillation. We'll give you some education about it. We'll do an EKG to see if you're still in normal rhythm, and then that'll help us get a sense of how far along you are with regards to your atrial fibrillation. We'll talk about reversible risk factors, things that you can do to try to prevent progression of atrial fibrillation. We'll see what other testing needs to be done, and then we'll make a plan to go to address the consequences of atrial fibrillation. We'll make a plan to prevent stroke, to control the heart rate, and to restore and or to maintain normal rhythm. And of course, we'll answer any questions that can come up. So the first goal, and really the most important goal, is to prevent stroke. As we mentioned, when the heart is out of rhythm, it's not pumping blood well. And when blood isn't moving well, it can clot, and those clots can go up and cause stroke. So we have to look at your risk for stroke and look at your risk for bleeding. The majority of people benefit from being on a blood thinner. Either the old blood thinner, Coumadin or warfarin, or the newer ones, Eliquis or Xarelto. We'll talk about the advantages of each of those in clinic. In addition to preventing stroke, we also want to control the heart rate. Atrial fibrillation typically leads to a fast heart rate. So we give medicines to try to slow it down. Even if you're not symptomatic, even if you don't feel palpitations and you don't mind how fast your heart is going, a prolonged fast heart rate can weaken the heart and cause heart failure. So it's important for us to keep the heart rate less than 110 beats per minute. And we do those with medications like metoprolol, diltiazem, or digoxin. The next part is to control symptoms, often by restoring normal rhythm. Now, some of you may have been diagnosed with atrial fibrillation because you were symptomatic. You may have had palpitations, you may have been fatigued, so maybe you went to the ER, or maybe you saw your primary care doctor and he or she did an EKG, and that gave you the diagnosis. Some of you may have had periodic palpitations, and we may have found it on an event monitor, or a Holter monitor, or even the Apple Watch. Others of you may be asymptomatic, whereas your atrial fibrillation may have just been diagnosed incidentally. Maybe you came to the hospital for something completely separate, like a colonoscopy or something, and they put on the monitors and they found you to be an atrial fibrillation. And some of you, it's not clear. Maybe you're feeling something, maybe you're not. We'll talk about how we can tease out how symptomatic you are and talk about the advantages of restoring normal rhythm. So you can live in atrial fibrillation. It is not a fatal arrhythmia, but you may not have to. It's important as you decide to intervene with regards to your heart to know the natural history of atrial fibrillation, the pattern of atrial fibrillation. And it's fairly consistent. In the beginning, people have brief episodes that come and go. As time wears on, those episodes increase in frequency and duration. And initially they go in and out, something called paroxysmal atrial fibrillation, and eventually they go into it and they stay into it, and they are in what's called persistent atrial fibrillation. If you're no longer going in and out of atrial fibrillation on your own, you often need a cardioversion or a shock of the heart to put you back into normal rhythm. If we don't do anything with atrial fibrillation, even that will progress to the point where the cardioversion doesn't last very long at all. Before we talk about how to restore and maintain normal rhythm, it's important that if there's anything that we can do, that we do it to modify our progression of atrial fibrillation. So we will check an echo to make sure that your problem is not related to a heart valve abnormality. We'll check your thyroid levels to make sure it's not a gland issue. And we'll often recommend lifestyle modifications. So if you're overweight, losing weight helps. If you have sleep apnea, or if you're not sure we need to look for it, treating that can help. Decreasing your alcohol intake, particularly if it's excessive, can help. And the same thing goes with caffeine or other stimulants. So back to our symptoms. As we mentioned, some people are completely asymptomatic, and some people feel it discreetly. So some people don't feel it at all, and some people feel it the minute they go into it. Most people are somewhere in the middle, where they don't necessarily feel it immediately, but they start to feel fatigue or short of breath somewhat gradually. What I often recommend is that we attempt to put you back into normal rhythm so you can feel the difference yourself and see how much better you would feel in normal rhythm. And you can tell. Oftentimes people don't feel their atrial fibrillation because their symptoms start gradually, and they just adapt to it. But with the cardioversion, we can put you back into normal rhythm, and you can compare how much better you might feel. But a rhythm control approach involves either restoring and or maintaining normal rhythm. There's no cure, I'm afraid, for atrial fibrillation, but we have some very good treatments for it. The things that we'll talk about are the cardioversion, or shock to the heart to restore normal rhythm, anti-arrhythmic medications, which can help keep you in rhythm for a period of time, and very briefly, atrial fibrillation ablation. That's a bigger topic, and we have a separate video about that, but I want to just bring it up for completion. So if you are still out of rhythm, what we will often offer is a cardioversion. That will, if you're not feeling well, will often make you feel better. If you're not sure how symptomatic you are with atrial fibrillation, this will help you figure out how much better you would feel in normal rhythm, and then that can help you decide what further treatment you want to have. A cardioversion is non-invasive. We put patches onto the heart and we shock it. It is, however, often paired with a transesophageal echo, where we look through the esophagus to make sure that you don't have a clot in the heart already. The good news is that it is very easy to get someone into normal rhythm The tougher news is that it can be difficult to keep them into normal rhythm. We'll talk about how we can do that. A cardioversion is an outpatient procedure, and typically I offer it to everyone who is diagnosed with atrial fibrillation who's not flipping back and forth, so that they can see how much better they would feel in normal rhythm. Oftentimes, the cardioversion doesn't stick, and people often need the aid of medication or an ablation to help stay in rhythm. Medications, there's only a handful of them, which are what's called anti-arrhythmic medications. Every single one of them has potential side effects, but they can help keep people stay in rhythm, at least for a period of time. Success rates are not great. Success rates kind of cluster at best 60% with our strongest medicines and 40 to 50% with our first-line medications. There's also an invasive procedure called atrial fibrillation ablation. We have a separate video about that. It is a vascular procedure where we actually go into the heart and we help modify where the atrial fibrillation comes from. This is our highest success at maintaining normal rhythm. In a good candidate, success rates cluster between 80 and 85%. So that is the big overview of atrial fibrillation management for your first clinic visit. We want to do an EKG and see if you're still in normal rhythm. We want to get a plan to help prevent clot. We want to make sure your heart rate is well controlled. And then we want to see if we want to restore normal rhythm and decide how we're going to go about maintaining it. So that's the big picture. I hope this helps. I understand that it can be a lot to take in all at once. It took me 10 years to learn about atrial fibrillation, so you take your time with it. But come to the clinic with questions, and your doctor will talk to you about your specific plan. We will individualize a plan for you, and in clinic we'll get going, and we'll try to get a good plan for your atrial fibrillation. I really hope this helps. Thank you so much for tuning in, and we will see you next time. Thank you.